Berks Community Health Center Presents on BCTV is supported by the Berks Community Health Center.
Hi, and welcome to Berks Community Health Center Presents. My name is Debbie Hartranft, and I am the Chief Community Relations Officer at BCHC. October was National Breast Cancer Awareness Month, and although October has passed, it really is a topic that should be top of mind throughout the year. Each year in the United States, about 240,000 women get breast cancer and 42,000 women die from the disease. And surprisingly, at least to me, 1 out of every 100 breast cancers diagnosed in the United States are from men. Joining me today is Dr. Michael Brown, the Medical Director of the McGlinn Cancer Institute at Reading Hospital, to discuss this important topic. Welcome, Dr. Brown.
Thank you. I'm glad to be here.
Thank you so much. I really appreciate it. You know, those statistics are pretty startling. What can you tell me about
They are. Unfortunately, next to skin cancer, breast cancer is the #1 cancer, that affects women. All women are at risk. Even women that have no family history are at risk. And we're not sure of the mechanisms of actually developing breast cancer. It's a world problem. It's not just a problem in the United States. But we support early screening because when we find things early and small, we have a very good cure rate.
That's wonderful. So let's talk about the symptoms. What are they? What should a woman be watching? Or some, I guess, men too, from what I'm understanding.
Most of the time, about 1% of breast cancers occur in men. And men can develop a lump in their breast, similar to a marble under the nipple, and that should be evaluated. In women, if a woman develops a lump, usually a firm lump similar to a marble or so, it should be evaluated. Sometimes there's redness of the skin, or there's a discharge from the nipple, a bloody discharge, or just an overall change in one breast versus the other breast, maybe a distortion of the nipple complex. Most breast cancer today is picked up when a woman has no symptoms. It's picked up on a mammogram. And a mammogram can give us a 2 to 3 year lead time before a woman might know that she has a lump in her breast.
Wow. You're talking about mammography. At what age, what are the recommendations now for?
There's a couple different societies that recommend mammography. The standard is starting at age 40 and to have a mammogram every year.
Okay.
Some of the older women ask, when should they stop mammograms? Some of the European countries stop at 75, but in the United States, if you're healthy and you wish to have a mammogram, we continue mammograms into their 80s if a woman wishes to do that. There's still some benefits with that. But we evaluate younger women. It's a woman who is of normal risk would be at 40, but a woman who might be at higher risk. And she may be at higher risk because either she has a family history of breast cancer, or she was diagnosed with a gene mutation like the BRCA1 and 2, BRCA1 and BRCA2, which you can develop breast cancer in your 30s. Those women were more likely to recommend MRI of the breast because their breasts are dense, and MRI is not associated with radiation. So we start that earlier.
Yeah. So how do you know if a woman has a gene mutation? What prompts them to get that test?
Right now we're recommending all women to have risk assessment by their primary care doctor, which is either their primary care doctor or their gynecologist. When they see a gynecologist age 20, age 25, the gynecologist will take a family history. And so it's important to know your family history. Do you have what we call first-degree relative? Mother, daughter, sister, or even a second-degree relative, such as an aunt or cousin that developed breast or ovarian cancer. because the
Okay.
breast and ovarian cancer are linked. And we would want to know at what age did they develop cancer? Did they develop a cancer under the age of 50? Because there's more likelihood that there may be a mutation if they developed cancer early, as opposed to saying, oh, your grandmother developed breast cancer when she was 90. That's not as much of a risk factor.
Okay, all right. So if that family history exists, then they typically they do a mammography, and you said an MRI,
Well-
but also a test. Is that a
Well,
blood
they would,
test?
if a woman with a risk assessment appears to be at risk, we would send her to our genetic counselor. We have a full genetic program. The genetic counselor would talk to the woman, and if she's appropriate, they would invite her to have testing if she wanted to have testing. And we think that knowledge is power. Knowing you have a mutation doesn't mean that you have to have any type of surgery, but it means that we would recommend follow-up visits and follow-up imaging so that we could stay on top of things so we don't miss anything.
Right. And is that testing blood work or?
Well, there's two types. You can have a saliva test or you can have a blood test.
Okay.
The blood test might be slightly more sensitive, but the saliva test is also very good. And we test a number of genes. Right now we're testing maybe 70 genes for breast cancer. Some of them are not as strong as the known BRCA1 and BRCA2, but some can be associated with other cancers. There's one called Lynch syndrome that can be associated with colon cancer or pancreatic cancer or gastric cancer, and that helps us counsel the patient as to what kind of follow-up or screening test they should have.
Okay, wow. So you were talking a little bit about the symptoms. I know it's strongly encouraged for women to do self-exams.
Right, there was a strong encouragement for women to examine their breast every month, usually in the shower.
Yeah.
And then there was some confusion that women, felt anxious because they felt everything felt like a lump. And then some of the societies had backed off and said, well, it wasn't as sensitive. But in my practice and in my experience, I think it is important to become aware of your breast. And it's a good thing to make sure that they're fairly symmetrical. So if you feel a lump on one side that's not on the other side, then I would bring that to the attention of your healthcare provider.
Okay. All right, so let's talk a little bit about the different types of breast cancer that there are.
Right. Well, breast cancer is sort of a progression in a way. You can first have an abnormality and we biopsy it and we call atypical cells. So it's called either atypia, atypical cells, or abnormal cells. That's sort of a pre-cancer where cells are building up on the inside of the duct, and we usually just simply excise that. But then it can grow into cancer cells that have not invaded into the tissue. They're in the ducts of the breast, but they haven't actually invaded. And it's called ductal carcinoma in situ. In situ is a Latin word for in place, meaning it didn't invade. We actually call that stage 0 breast cancer, and we excise it and we add radiation so it doesn't come back, but it's very curable. It's stage 0. And then,
Is it noticeable in a mammogram?
yes,
Okay.
it's usually noticeable by specks of calcium that are clustered together.
Okay.
So when you look at a mammogram and it gives you an image of the breast, we're looking for either a mass, similar to a pea or a jelly bean, but it might be more shaped like a star, spiculated, star-shaped, or we're looking for clustering of calcification, usually 4 to 6 specks of calcium that would be in the area of a eraser on a pencil. That's how tightly they're combined. There's a couple different types of breast cancer. The main ones are called ductal, coming from the duct, or the lobial. The lobial is the little unit that makes the milk, and then it flows through the ducts onto the nipple. Most cancer occurs in the ducts. But the biggest differentiation in breast cancer is what's called the receptors. There's two main types. There's women who are estrogen positive, where their tumor has receptors for estrogen, and estrogen can make the tumor grow. And there's women that are estrogen negative. There's also progesterone positive, progesterone negative. That's also a woman's hormone. And then there's another one called HER2. This tumor can often make cancers grow very fast. It only occurs in 50% of breast cancer, but it tends to be fast. If you're estrogen positive, where 70% of tumors are, you can often be treated with an anti-hormonal pill, an anti-estrogen, after your surgery and radiation. If you're estrogen negative or you're HER2 positive, you're more likely to have to take chemotherapy or drugs for those receptors.
Okay, wow. So the specific risk factors, you talked a little bit about heredity.
Right. Heredity,
genetics.
family history. Some of the other risk factors are lesser risk factors, but a woman who's never had children is at risk. A woman who may have had her periods late or delayed childbirth for a long time has slightly higher risk. Your risk goes down when you have children early. It interrupts the estrogen within the body, and it may give some protective effect, but that's small compared to really family history. And the next biggest risk factor is breast density. Some women have very dense breasts, and there's two problems with dense breasts. One is it can make it difficult to see things on mammogram, and the second thing is we think that dense breasts are more hormonally active and may have a higher risk of cancer. So under the new recommendations, women that have dense breasts are usually recommended to have supplemental imaging, mammography plus MRI, and we think that we can catch cancers earlier that way.
What's a diagnostic mammography?
So when a woman has no symptoms at all, she has a screening mammogram, which is usually two views of the breast, a top to bottom view and a side to side view. If the radiologist sees something abnormal and he wants further pictures, then we order a diagnostic mammogram where they'll do spot compression and often different views to characterize, is this just a shadow or is this really a density?
Yeah. I imagine the occurrences of shadows, you really have to be skilled to be able to read those, and
yes.
I imagine that happens a lot.
Yes. Now, since we have digital mammography, we have programs embedded in the mammography called computer-assisted diagnosis. So a computer is looking at that for any abnormal patterns and then signals to the radiologist that, oh, this pattern is off, and then the radiologist can investigate it.
Oh my
so
goodness.
It's very exciting that we're already have been for years using computer-assisted diagnosis, and we think the next step is to use artificial intelligence to be involved. And they're already having programs to try to get better and better to pick up smaller and smaller abnormalities within the breast.
That's amazing.
It is. It's very exciting.
Wow. Wow. So breast density was the next topic we were going to talk about, and you pretty much just described that.
Mostly your density will go down throughout life. Usually, that's why we don't necessarily recommend mammograms for young women. Breast cancer usually doesn't occur too much in your 30s. It usually starts taking off at age 40 and above, and it goes up throughout your life. That's why looking at the statistics of breast cancer, the societies are saying at about age 40 is the appropriate time to get a mammogram. If your breasts are dense, they would talk about possibly getting an MRI. If you've had children, sometimes your breasts are less dense. If you go through menopause, your breasts become less dense, and then the mammogram becomes a better tool at finding things.
Oh, okay. Well, that makes sense. So the role of genetic testing and family history, you touched on that. Is there anything further you want to talk about in that topic?
Well, no, the knowledge is power, and so it's important to know your family history. In generations past, they didn't talk about it so much.
I was just going to say.
And so a lot of people said, I don't know. They said that a relative might have had cancer, or it might have been all throughout them, and and they didn't really know the specifics. So it's nowadays, we have a better knowledge of these things, and families say, well, was it ovarian cancer? Was it uterine cancer? And at what age did the relative have? So, I think families share a lot more knowledge today than they might have done 2 generations ago.
Right, yes. So how do we lower our risk for breast cancer?
Well, it's very difficult. There are some general recommendations, which is really general health recommendations. Try to maintain a healthy weight and limit alcohol intake. Those type of things can, a balanced diet, which really goes to maintaining a healthy weight. We don't have, outside of that, we don't have any specific recommendations. We do recommend anti-hormonal medicine for women that are at very high risk. Somebody that may have, abnormal biopsies of the breast, we may start them early on anti-hormonal medications, or, women that have a high family history, we may start them on anti-hormonal medications early before they develop cancer. One of the downsides is these medications can have some side effects that can be unpleasant. Hot flashes, they can have some arthritis type symptoms, they can be associated with blood clots. So we make it very, we don't recommend them for everyone. The risk has to be high enough to have the benefit from taking those medications.
Okay. We were talking about symptoms earlier, and what about pain? Any pain you're experiencing in your breast?
Usually, breast cancer doesn't hurt. So, nothing's always, but usually breast cancer doesn't hurt. So women often will have discomfort in their breast. Usually, with young women, it goes with their cycle. And young women can have cysts in their breast that will feel like a mass, and when we do an ultrasound, we see it's a cyst filled with fluid, but we still investigate it and we might aspirate the cyst. You can also have solid lumps in your breast, usually as young women, from teenager on to through your 20s to your early 30s, called a fibroadenoma. This is a benign mass, some fibrous breast tissue, but it forms like a little lump, like a marble, and can be, cause a lot of anxiety to the woman. So we evaluate those type of things.
Okay. So let's talk about the mammograms. You said who should get. Now, for a moment, men, risks same?
The risk for men is that men can harbor the gene also,
Okay.
BRCA1 and BRCA2, and it can be in the family. So if that gene is in the family, men will often present with early prostate cancer. So if they have early prostate cancer, they also get tested for the BRCA1 or BRCA2 gene. Usually men, it's a rare event to develop breast cancer, but usually men can feel things, so we don't necessarily do mammograms on men, but if they have a lump, we evaluate that. There's a couple myths about mammography. There's a myth that mammograms cause cancer, and that's not true. No one wants to be evaluated or to have a positive mammogram or to go through that. But mammograms save lives. And we've had the first diagnosed case of breast cancer was in the Egyptians that built the pyramids. And we have documented evidence going back, that they had breast cancer in those civilizations. So breast cancer is not new. And with the advent of mammography since the late 60s and on, we've been doing a much more successful job at finding breast cancers, saving the breast, and curing the disease. There's mammograms may be a little bit uncomfortable, because you're being compressed.
Oh, they are.
The mammogram techs are very skilled. They do hundreds of mammograms every year, and it's only for a short time, and the benefits are well worth the inconvenience.
I absolutely agree. Absolutely. So, just focusing on men just for a moment, should they be doing self-exams periodically?
Well, you should be aware of your body.
Right.
And it can be uncomfortable to talk about, but in men, you know, in a general statement, you know, you want to be aware of, you know, young men, if you would have a lump in your testicle, because testicular cancer would be common among young men, but also if your bowel patterns change, if you're losing weight, if you notice any lumps in your neck, under your arm, you know, if you're noticing lumps on the chest, they should all be brought to the attention of your healthcare provider.
Right, right.
Also, the biggest thing now, you know, talking about both men and women, is looking at your skin, because melanoma has increased in the population with our, you know, we're more sun exposed. And so that if you have a skin lesion that looks odd, different colors, bleeds, you know, that should be brought to the attention of your healthcare provider.
Yeah. So Reading Hospital introduced a mobile mammography unit a few years ago.
We're very excited about the mammogram coach.
Yes, yes, and it comes to some of the Berks Community Health Center locations, which we're very grateful for.
Yes.
Tell us a little bit about this unit.
Well, it's a brand new mammogram coach that has the latest technology. It's the same technology, and we bring the mammogram coach to the community. So it may be easier to people that have transportation problems. They can go to the coach. They can get their mammogram on the coach. It's read by the same team, and we're really excited about it. We've only been rolling out a year, and we continue to expect that it will grow at community events. We're looking at ways of signing people up to use the coach and to have more partners with the coach.
Yeah, so they still call and make an appointment. It's not a walk-up situation.
It's not a walk-up right now. We're working on the processes, because you really need to have a doctor who's going to be responsible for the results. We don't want you to have a mammogram and then there's no health professional responsible for the results. But we're working to resolve that. And we certainly have enough funded free mammograms for women who may be underinsured or without insurance at this time. You know, the hospital has a foundation that provides for free mammogram. Each month we have a screening clinic for breast and cervical cancer that we screen women at the hospital. And you know, you meet with a financial counselor or a social worker. If you have insurance needs, we have ways to make sure that they get the care they need.
That's wonderful. Yeah, as I mentioned, the unit has been at Berks Community Health Center at our Penn Street location, up the street from the studio, and at our Rockland location. So we try to promote to our patient population as well as the community about the opportunity to get mammograms.
Well, it's programs like this that are getting the word out that we have the services in our community. And you know, at Tower Health Reading Hospital, we are very dedicated to the city of Reading and providing everybody with the health care that we think you should have.
Absolutely. So is there a special number that viewers should call to schedule onto the mammogram unit?
They can schedule the central scheduling number, which is online. And we also have scheduling through My Tower Health, the online portal. For Tower Health, which is very easy if you're computer literate, or the central number will help you with scheduling.
Okay. So is there anything I missed? Anything you wanted to point out?
When you're faced with a possible diagnosis of breast cancer, then you talk about treatment. Obviously, you want to preserve your breast. And we've become very good at that. In about 70% of the time, we can preserve your breast. And that's called a lumpectomy or partial mastectomy, where we make a small incision, usually a cosmetic incision around the nipple complex that you can barely see, and remove the tumor. And we back that up with radiation, and the woman has a very good cosmetic result. Sometimes it's better to remove the breast. If the tumor is very large, if there's multiple tumors in the breast, or if a woman has a gene mutation where she's at risk of developing more breast cancers down the line, she may elect to have the breast removed, but we have really good reconstructive services so that we can usually reconstruct the breast with either breast implants or tissue reconstruction, and we do that usually at the same operation.
Really?
Yes.
Okay, wow. What is the percentage, the risk associated once you had it to get it again?
Well, it's it's probably around 10%,
Okay.
and so it's not very high.
No.
So when women get a diagnosis of breast cancer, their first thought is, I should just have my breast removed. But it's not true. We're curing well over 90% of the women. The risk of having it come back is very small, and the survival of keeping your breast with radiation as opposed to having your breast removed is the same.
Really?
So, and the complications with a mastectomy are much higher than a lumpectomy. Plus, it's a cosmetic change. It's a different change to the patient, and we're very happy to be able to conserve the breast in the majority of cases.
Oh, that's wonderful. We've come a long way.
Yes, we've definitely come a long way.
Absolutely. That's wonderful news. Anything else you want to share? We're just about at the end. But
No, I would just repeat, find it early, fight it hard. And I think that, once you've had your first mammogram and you go through it and you're used to it, then you're like, I can do this. And go with a girlfriend. Get your buddies to go. And then once you've had a good result, talk it up. Be a breast advocate. And I think that's the best way that we can serve our community.
I think the data that you shared here today certainly speaks to that. And yeah, it's uncomfortable, but it's seconds, really, each image. So, well, thank you so much.
Oh,
I really appreciate
thank you for
you
having
coming.
me. I appreciate
Oh, it's our pleasure. Please, anytime you want to come back, let me know. And to our viewers, Dr. Brown really has some really good points. And get your mammogram, talk to your primary care provider, be aware of your body. He has some excellent tips here today to try to keep you as healthy as you can be. And I appreciate you joining us this month, and stay tuned next month for Berks Community Health Center Presents.
Berks Community Health Center Presents on BCTV is supported by the Berks Community Health Center.